So this lecture is coming from the Journal of Medical Ethics blog from April 7th, 2020. It was written at the very beginning of the pandemic when medical professionals were having to figure out how to allocate scarce medical resources for patients suffering from severe cases of COVID-19. In this blog, New Zealand bioethicist Angelina Ballantyne argues that the current triage protocols rely too heavily on the principle of utility at the expense of equity. This tends to result in advantages to those who are already privileged over those with very little privilege. When in doubt, these rationing schemes should use broader criteria rather than narrow criteria, even if this is at the expense of maximizing utility. It was estimated that 5% of COVID-19 cases would require ICU care. Obviously, this made hospitals nervous because they were going to have to start rationing scarce medical resources. In light of this, bioethicists from around the world were called in to consult on hospitals' rationing triage protocols. Today, we're looking at an article from New Zealand bioethicist Angelina Ballantyne. She starts by setting aside other principles such as reciprocity for frontline workers because of the risk that they're taking, or considerations for younger people because they are going to have a larger portion of their natural lives to lead. Instead, Ballantyne sees the main ethical tension as between the principle of utility and the principle of equity. The World Health Organization defines health equity as preventing remediable differences among groups of people, whether those groups are defined socially, economically, or demographically. So she does not give a clear definition of utility, but she's clearly appealing to this utilitarian notion, or sometimes in economics, but specifically here it's going to be the notion of the most amount of lives saved. Ballantyne does not think that we can simultaneously prioritize the principle of equity and the principle of utility. She sees this as an exclusive or. Either we can save the most amount of lives possible, or we can save the most diverse group of lives. Many have traditionally argued that the many is more important than the who. For instance, Dominique Wilkins says, in a situation where resources are overwhelmed and choices cannot be avoided, the ethical balance must shift to emphasizing benefit. This will mean prioritizing intensive care for those patients who have the highest chance of surviving. Ezekiel J. Emanuel and colleagues said, priority for limited resources should aim both at saving the most lives and at maximizing improvements in individuals' post-treatment length of life. Saving more lives and more years of life is a consensus value across expert reports. Andrea Gruna says, as a basic rule, we try to act in such a way that the largest number of people survive, because that is in the public interest. These positions are going to advocate for saving the most lives possible. They consider the principle of utility as weightier than the principle of equity. Although Ballantyne cheekily points out that it's going to be no surprise that these guidelines have been legally challenged on the grounds of discriminating against disabled people. She thinks that factors such as implicit bias will likely lead to these triage protocols discriminating against the elderly and disabled. Jackie Leach Scully argues that the current triage guidelines are an indicator of our ongoing inability as a society to consider people with disabilities as equal members of the community, with equal human and civil rights, equal claim to citizenship, and equal moral agency. Ballantyne has two main focuses in this post. First, she's going to consider how utility-focused triage approaches are going to impact healthcare disparities. But she also wants to try and answer the question of why equity as a principle has been deprioritized. So she acknowledges that these rationing schemes are not going to be expected to resolve all healthcare inequalities, but that does not mean that we should uncritically default to maximizing the principle of utility. Ballantyne acknowledges that there is going to be a point at which admitting a new patient to the ICU with very low survival is going to be tantamount to a failed stewardship of public services. Nonetheless, there's going to be a middle ground here between maximizing ICU resources and thoughtlessly throwing them away. Ballantyne thinks that in this middle ground, we should deprioritize utility to give a wider range of people a fair opportunity at receiving these life-saving medical care. Contrary to the dominant view, Ballantyne argues that protecting both the principle of equity and justice is also in the public's interest. To be clear, Ballantyne is not trying to say that utility-centered approaches are going to explicitly endorse discrimination, but rather that these forms of discrimination are going to be byproducts of prioritizing certain groups of people. Specifically, younger, white, wealthy people, or generally people with more privilege, are going to be favored by these rationing approaches because they are more likely to benefit from these resources. But that's only because they have, on average, a higher baseline health status. Hypertension, cardiovascular disease, chronic obstructive pulmonary disease, and cancer are comorbidities that are likely to cause serious complications with COVID. Unfortunately, comorbidities are not evenly distributed amongst the population. Baseline health status is often correlated with privilege that is often afforded by one's ethnicity or wealth. In New Zealand, prevalence of multimorbidity, 2 or more conditions, is higher in Māori, 13.4%, and Pacific Islander ethnic groups, 13.8%, than for New Zealand Europeans, 7.6% prevalence. Māori, age 45 and over, have COPD hospitalization rate over 3.5 times that of non-Māori. So if these factors are included in ICU triage protocols that aim to maximize population survival rates, then these results are going to reflect the social and economic inequalities. Further, these inequalities are pronounced in individuals' exposure to the coronavirus. According to US cell phone data, individuals in higher income areas were able to reduce their mobility significantly more than individuals in lower income areas. This suggests that the ability to socially distance is a luxury that not everyone can afford. So looking back at the history, in previous epidemics in New Zealand, Māori and Pacific Islanders have been disproportionately impacted. In these previous pandemics, this impact was not directly caused by rationing schemes that prevented access to ICU, but nonetheless, the history of disproportionate impact reflects that these populations are vulnerable and often lack access to adequate medical care. In the 1918 pandemic, ICU was not invented yet. It hadn't been invented until 1950, and so it was not a relevant factor. Nonetheless, the Māori died at 8 times that rate of the Europeans living in New Zealand at the time. During the 2009 H1N1 pandemic, ICU access did not need to be triaged, but mortality rates were 2.6 times higher for Māori and 5.8 times higher for Pacific Islanders compared to European New Zealanders. Maximizing the number of lives saved is a function of 1, prognosis, and 2, the length of benefit. The first is the chance of survival based on the diagnosis, and the second one is how long each patient is likely to need ICU care. One of the prominent objections to the principle of utility and utilitarianism in general is the accuracy of the predictions. Standard scoring systems are meant to help predict how much benefit a patient might receive from ICU care. So here we're going to look at 3, Apache 2, sequential organ failure assessment, and the simplified acute physiological score. So Apache 2 uses the point score based upon initial values of 12 routine physiological measures, age, and previous health status to provide a general measure of the severity of a disease. The sequential organ failure assessment score is a scoring system that assesses the performance of several organ systems in the body: neurological, blood, liver, kidney, and blood pressure, to assess the score based on the data in each category. The simplified acute physiological score estimates the probability of mortality for an ICU patient on admission. The SAP-3 score predicts hospital mortality upon ICU admission using patient's characteristics, indication for ICU admission, and physiological derangement upon ICU admission. But so how reliable are these scoring systems going to be at predicting survival of COVID-19 patients in particular? In China, the overall case fatality rate, CFR, was 2.6, but the CFR was higher for people with comorbidities. 10.5 for cardiovascular disease, 7.3 for diabetes, 6.3 for chronic respiratory disease, 6% for hypertension, and 5.6% for cancer. Data from the UK found that 7 patients, 42% with comorbidities, survived the ICU, while 10 patients died, 58%. You need to remember that this was written very early on in the days of the pandemic. It was posted April 7th of 2020. So there wasn't a lot of data to go on at the time. Ballantyne questioned whether we had enough data to deny patients with comorbidities access to the ICU. She contends that if we're going to deny people access to life-saving interventions, then we need to have a high degree of certainty that the triage protocols are actually maximizing lives saved at the population level. Ballantyne does not think that we have enough to be reasonably certain yet. She acknowledges that she is not a medical professional and she's not trying to interpret the medical data or speak about the reliability of these ICU scoring tests. Still, as a bioethicist, when she is asked to consult on these rationing schemes, Ballantyne thinks that we need to really challenge screening measures that are going to be excluding patients from consideration. When there is uncertainty, as it was in the early stages of the pandemic, Ballantyne argues that rationing schemes should be more inclusive to give more people a chance at life-saving medical care. Specifically, she says that schemes that use quality-adjusted life years, QALYs, should be avoided because they are inherently discriminatory against people with disabilities. Also, Ballantyne suggests that in the meantime, we should allow for some time-constrained ICU trials, but we should also develop protocols for removing a person from ICU care because it needs to be given to someone else. Ely Dowtry-Bitson and her colleagues advocate for the following approach: to address concerns about compounding injustices associated with systematic disadvantage and the arbitrariness of comorbidities, and unlike other approaches that have been proposed for ICU triage in disasters, the scoring system described here affects patients whose comorbidities are so serious that they are expected to live no more than 12 months, even with successful ICU treatment. Regardless of the total amount of lives saved, the medical community needs to offer a narrative about the principles that guided us through this crisis. The narrative that emerges from the pandemic is going to have a lasting impact on the legacy of bioethics and the medical community. Yes, the medical community has a responsibility not to waste life-saving treatment, but Ballantyne does not think that necessarily entails that we should default to maximizing utility. The public also has an interest in reaffirming human rights, the value of diversity, promoting fairness, and resisting entrenched privilege.